process. And next slide. There's also been specialty-specific changes. So the Royal College of Emergency Medicine have created their own credentialing process for ACPs working in emergency care. So in this credentialing process, ACPs undertake the Masters in Advanced Practice, but alongside this, they complete an e-portfolio. So the e-portfolio is where they do workplace-based clinical assessments and they submit their evidence to the e-portfolio and to demonstrate they are meeting certain clinical competencies associated with the ACP curriculum. Once they've completed their e-portfolio, they submit this to a trained panel who then assess that evidence to see whether they've met the standards to become a credentialed ACP within emergency medicine. So the next slide. So just to summarise so far, I've talked to you about what an ACP is. I've talked to you about some of the advantages of this role and some of the challenges they have faced. I've also talked about some of the things that have been done to address some of the challenges that have happened historically. So next slide. So now I want to move on to talk about the first study that I worked on. So in this study, we're interested in exploring ACP perspectives on their training, their role identity, and how they gained clinical competencies. Next slide. So this was a qualitative study, which involved doing 5 focus groups with 14 ACPs. We include both qualified and trainee ACPs who were working in either mental health, community, or secondary care across the South Yorkshire and Bassetlaw region. And next slide. Before I talk about the results, I just want to talk about the timing of this study. So this study took place in 2021, which was right in the middle of the COVID-19 pandemic. Up until this point, all the data collection we'd done have been through face-to-face interactions. But obviously, due to government restrictions at this time, we could no longer do our focus groups face-to-face and had to move to online methods. As a research group, we were initially quite anxious about this. Would we have technological issues? Would we get the same level of depth of conversation that we're used to through face-to-face focus groups? So we sought a lot of advice from fellow researchers who were a little bit ahead of us in terms of doing online focus groups. On reflection, I think we still got the level of detail and in insightful comments from our ACPs moving it online. It worked really, really well. 5 years later, obviously, online data collection has become the new norm. And it's funny to reflect back and think how anxious we were making that transition into online data collection. And really, they have lots of benefits now doing things online compared to relying on face-to-face data collection. Next slide. So overall in this study, we identified 4 themes, and I'm going to walk you through each of these 4 themes now. Next slide. So the first theme was the differing experiences between the academic and the clinical elements of ACP training. So the academic element of ACP training is their Masters in Advanced Practice they undertake at the university. And the clinical elements is the on-the-job workplace-based clinical skills training. Next slide. So in this study, ACPs are really happy with their academic elements of their training. They felt it was really well supported and well structured. So one ACP said, "It's really supportive and I've made some really good friends there and everybody supports each other." The next slide. However, when it came to the clinical elements of their training, ACPs were much less satisfied. They felt like their workplaces hadn't really planned for their ACP training. They were very much left to their own devices. They had to find their own medical supervision and they also had to organise their own placement opportunities. As one ACP said, "I was completely unsupported by the trust because they just weren't set up for it. There was no one leading on it. There was no one for us to contact really to talk to. And then, like you said, I got my placements from begging on a forum on Facebook and a nurse set me up." Next slide. So there are also issues with line management. So what we found was that ACPs were still being line managed by someone in their baseline profession. So for example, nurses were still being line managed by nurses. This was fine to a point, except that people in their baseline profession didn't really fully understand the advanced skills and clinical skills that ACPs are now expected to undertake. So ACPs kept saying that they were really lacking that medical supervision. So the second theme is around how ACPs gain their clinical competencies. So ACPs described it as a very topsy-turvy process. So ACPs entered their training feeling really confident. These are highly skilled professionals who have often been working in their baseline profession for 10, 15, 20 years. So they felt like they were really confident. However, what they quickly realised was that they'd learned a lot of their clinical skills through pattern recognition. They compared themselves to junior doctors who spend a lot of time at medical school learning about the underlying pathology. ACPs quickly recognised that they have this massive knowledge gap in their clinical knowledge. And so they had to spend a lot of time rebuilding their confidence through their training. Next slide. The second issue was around time. So what we found was that ACPs were still doing roles and responsibilities associated with their baseline profession. They didn't really get dedicated time and space to focus on their ACP training within the workplace. So as a trainee ACP said, so say, for example, you're sat with somebody talking about their prescription and trying, looking to see if there needs to be a change made. And then you've got people banging on the door saying, I want to go on leave and I need this and I need that. And you're the nurse in charge and need to be doing that. So next slide. The third theme was around perceptions of the ACP role. So ACPs talked about workplaces not really understanding what the ACP role is. And they were, again, as I mentioned just now, they were still doing roles and responsibilities associated with their baseline profession, and the ACP role almost felt like it was tagged onto the end of all their existing roles and responsibilities. It wasn't really seen as that distinct and complementary role that we're trying to achieve with the ACP role. Next slide. ACPs themselves are also unclear about what the ACP role is and where they fit within the NHS workforce. So one of the things that they talked a lot about was the uniform and how a uniform identifies you within the NHS workforce. So I had one ACP said that, well, doctors wear purple scrubs and nurses wear green scrubs. And so they went to the trust and said, well, what uniform do you want me to wear? And they said, well, wear a purple top and green bottoms, and that'll distinguish you as an ACP. Next slide. So the final theme is around perceptions around the future of the ACP role. So some people were really positive about the ACP role. They said, the one thing that I do know is I love the job, I love the role. Whereas other people are a little bit more sceptical. For example, one ACP said, I don't see much career progression within ACP, other than to become a lead ACP. Next slide. Overall, there was agreement amongst the ACPs that there needs to be greater clarity and increased awareness of the ACP role within the workplace and the wider NHS workforce. They felt like confusion around role identity was the root cause of a lot of the challenges they'd experienced within their ACP training and transitioning into this new role as an ACP. So next slide. So overall, in conclusion, from study one, what we found was that ACPs reported challenges related to their clinical supervision and support within their workplaces. In many cases, ACPs continue to be expected to fulfill duties aligned with their original professional roles, and that limited their ability to fully apply the advanced clinical skills acquired through ACP training. These issues often stemmed from a lack of understanding or awareness of the ACP role among employers and colleagues. To address this, further work is still needed to promote a clear understanding of the ACP role across healthcare settings, ensuring that ACPs are effectively supported and utilised to their full potential. Next slide. So now I want to move on to talk about the second study I worked on. So this study was looking at the training experiences of ACPs training in emergency care. So in the southwest of England, they'd introduced a new pilot training programme for ACPs working in emergency care. Before the pilot was introduced, what they found in the region was that trainees were taking a very long time to progress through their training and reaching that RChem credentialing endpoint. So they wanted to see whether if Health Education England provided enhanced funding and support to individual emergency departments, whether this would increase the rate of progression in which ACPs moved through their training. Next slide. So now I want to just talk a few moments about the Southwest pilot. So as with all ACPs undertaking this new pilot training programme did the Masters in Advanced Practice, and they also did the RChem credentialing pathway. So as I mentioned earlier, so in the RChem credentialing pathway, ACPs undertake workplace-based clinical assessments. They then upload their evidence to an e-portfolio to demonstrate how they have developed their clinical competencies associated with the ACP curriculum. They then send that to a trained panel who then assess it to see whether they've met the standards to become a credentialed ACP in emergency care. However, over and above this kind of baseline ACP training, Health Education England provides some enhanced elements So the first one was providing enhanced funding to the emergency departments to allow trainee ACPs to be supernumerary. So this is where they weren't counted in the numbers when they were on the shop floor in the emergency department, and they had dedicated time to focus on their ACP training. They also got access to specialty-wide placements in anaesthetics, ICU, and acute medicine. These placements were organised for them. It wasn't something they had to do themselves. Health Education England also wanted to create regional peer support to create a community of practice for trainers and trainees. They also organised regional training events and annual reviews of training. So ACPs in this pilot, for the annual reviews of training, it was 2 qualified ACPs who would go and check in with the ACPs on a yearly basis to see how they're progressing and also if they could address any challenges they're experiencing. They were also assigned an educational supervisor, which was usually an emergency department consultant. Next slide. And again, the COVID-19 pandemic derailed some of their plans. So understandably, the ICU was full of COVID patients, and so it wasn't always appropriate for trainee ACPs to go and do placements in the ICU. So not all of the trainee ACPs got to go out and do the placements as originally planned. Also, things like the community of practice and online training and regional training events, they didn't go ahead as planned because understandably the NHS was overwhelmed with COVID patients, and also due to limits with restrictions on face-to-face interactions, those elements of the training programme didn't go ahead as planned. However, despite, However, despite some of the things not going ahead as planned, we still went ahead with our evaluation and got some really, really insightful and interesting findings, which I'm going to talk to you about now. Now, next slide. So overall in this study, we spoke to 25, so we did 25 semi-structured interviews across the 5 emergency departments in the southwest of England that had introduced this pilot training programme. We're very interested in speaking to 3 groups of people. So we spoke to the ED consultants who were supervising the trainee ACPs. We spoke to the trainee ACPs who were participating in this pilot training programme. And we also spoke to trainee ACPs who had started training in these emergency departments before the pilot had been introduced. Next slide. So overall, in this project, we identified 4 themes. And again, I'm going to walk you through each of these themes now. Next slide. So the first theme was around aligning the Master in Advanced Practice and the RChem credentialing portfolio. So like with the previous study, ACPs talked a lot about how they'd gained their clinical skills through pattern recognition, and they're comparing themselves to how they'd learned their clinical skills to junior doctors, and that they did have this in kind of missing knowledge gap around the underlying pathology. So this is a really nice quote I like from one of the consultant supervisors talking about this kind of knowledge gap in ACPs. And they said, I had this light bulb conversation about 4 years ago with one of the trainees who's now a senior ACP, and I asked her something about cardiac output, and she just looked at me like this, kind of like, come on, you know about the heart, tell me about this. And I just realised like how little basic science they knew. Next slide. However, in this study, ACPs spoke really positively about their workplace training. So they described lots and lots of opportunities to increase their knowledge, clinical knowledge, through workplace-based, through supervision by medical colleagues. These weren't always formal interactions. They also talked about their wider colleagues being really supportive and lots of informal interactions and opportunities to kind of increase their clinical knowledge. They also really valued the ones who were able to go out on placements, really valued the opportunity to go to placements outside of the emergency department. And they really liked seeing what happens to patients once they've left the emergency department and considered that a real strength of the pilot. The next slide. When it came to the Master in Advanced Practice, there were differing views about how relevant this was to their training. So some of the modules were rated really highly, such as physiology and prescribing modules, are seen as really, really relevant and really useful. Other modules within the Master in Advanced Practice were seen as more of a tick box exercise, such as the Leadership and Innovation module. Next slide. However, one of the things that came out quite strongly from the ACPs was that they didn't really feel like the Masters in Advanced Practice was equipping them with the kind of clinical knowledge they needed to fulfil their roles within the emergency department. So this is summed up really nicely by this quote by a trainee ACP. They said, I think there's a stark difference. I mean, even if you compare us to physician's assistants, they're sort of biomedical degree. And I think their understanding of, you know, basic pathophysiology, biochemistry, just the way they're educated is very different to us. I don't think the Master in Advanced Practice programs provide that. They certainly help, but not the, sort of molecular level that doctors train at. You have to learn that yourself as you go along. Next slide. So the second theme in this study was around allowing flexibility in the timeframes in which you're expecting ACPs to progress through their training. So in this pilot training programme, emergency departments were provided with 3 years of funding to deliver on this training programme. So colleagues within the emergency department felt that meant that there was an expectation that ACPs needed to be ready for RChem credentialing after 3 years. However, they talked about that when ACPs enter training, they come from a whole wide variety of professional backgrounds, and they have differing levels of clinical skills and competencies. Also, as they progress through their training, obviously significant life events happen. Some people might take parental leave, others might experience bereavement, and all of these things affect how quickly ACPs will progress through their training. So what they were arguing is that there needs to be some flexibility built into the timelines in which ACPs are expected to reach the RChem credentialing point. So some ACPs may take 2 years, whereas others may take 4 or 5 years. And it's just working with individual ACPs to see what is achievable for them, rather than setting very specific rigid timeframes. Next slide. The other challenge was that some ACPs enter ACP training having already completed the Masters in Advanced Practice, and they were almost seen as having a bit of an advantage. Whereas other ACPs were having to complete the Masters in Advanced Practice, whilst also doing the RChem credentialing e-portfolio. The ones that were doing the Masters and the e-portfolio at the same time talked about an overwhelming workload and really struggling to balance different demands within their ACP training. So this is summed up really nicely in this quote from a trainee ACP. So they said, the modules kind of come pretty quickly in the back-to-back. You don't really have any let-ups in the university side of things. And like I say, your SPA time gets eaten up by university time. That then doesn't give you time to concentrate on your portfolio. Then you end up in this cycle of getting nowhere fast, or being sort of overwhelmed with workload. You can't continue to work at 120% all the time. I don't know how long that will be sustainable. Next slide. So the third theme was the ACP's experiences of their supervision and teaching. So what we found with ACPs is that moving into ACP training was very different to how they'd been trained in their baseline profession. So they were now being moved into a medical model of training. So this has been described again really well by a trainee ACP. They said, for 10 years, no one's ever stepped foot in the ambulance and saw me assess a patient. Whereas in medicine, obviously it's a constant cycle of being assessed by your peers and getting feedback. You're in this constant feedback loop, which is completely new to us, but it makes you feel really supported compared to where we've all come from previously. Next slide. So another thing that we found was that in this pilot programme, any patient that the ACP saw had to be physically assessed or at least have a clinical conversation with a senior ED clinician before they could discharge any patients from the emergency department. So this was a safety netting while ACPs were early in their training. Some ACPs struggled with this initial loss of autonomy. So again, these are healthcare professionals who've been probably leaders in their baseline profession, and now they're having to kind of run patients past senior clinicians before they can do any discharging. So one ACP said, I felt initially like my wings were being clipped. However, lots of ACPs really valued this safety netting and acknowledged that when you step into the role, you don't know what you don't know. So the next slide. Also, there was issues around time. So for the RChem e-portfolio, ACPs need to undertake workplace-based clinical assessments. This is where senior clinicians within the emergency department assess them undertaking some sort of clinical skills. Then they could write up a reflection and add that to the e-portfolio. But there were challenges finding time to kind of do those workplace-based assessments. So from a trainee perspective, they said, so in 10 minutes when you're set up, about to do a procedure, and they don't turn up because there's something else that's unfolded, you're not going to delay that patient's care. But at the same time, it's very disappointing that I've had this perfect opportunity and there's no one to see it. Equally, a consultant supervisor talked about the challenges they have in terms of finding time to deliver training and supervision. So they said, if you're staffing 50 ambulances and the department looks like it's on fire, and it's really hard to then amend supervision for some of those who are working reasonably slowly and needs all of their work double checked. Next slide. So we got a lot of insights from the consultant supervisors about the challenges of delivering supervision and teaching. So they said that supervision teaching shouldn't land on a single consultant. It should be something that's shared amongst the consultant team and to make the workload more manageable. Some of the sites also took part in an RChem educator pilot. So this is where consultants were provided with protected time to deliver training and supervision, and they weren't being pulled into other roles within the emergency department as things unfolded. And they found that really, really helpful. And again, that wasn't just for ACPs, that was also for junior doctors in the department. So as any trainees in the department could, and it would give them protected time to support them. The next slide. So the fourth theme is around transitioning into the ACP role. So what we found was that the transition from baseline profession into ACP was really, really challenging. So here's a couple of quotes from the ACPs. They said, "I felt like I'd been drop kicked into the fire. And it's probably the most extreme kind of process I've ever been part of." Next slide. One of the reasons for this kind of difficult transition into the ACP role, again, stemmed back to an unclear role identity. So as one ACP said, "I wasn't part of the doctors, I wasn't part of the nurses, I didn't really know where I fit. It was just a difficult transition." There was also evidence that ACPs were kind of not wanting to fully embrace the ACP role and were still kind of feeling more comfortable back in their baseline profession. So they weren't fully embracing this new role. So as one ACP said, "I still see myself as a paramedic. I still see myself in that role, but with the ACP attachment to it." Next slide. However, one of the things that really did help with the transition was that peer support. So getting support from other ACPs who understood the transition that you're going through, and just being able to provide that element of support. So here's a quote from a ACP that said, "Just knowing that the other people that are training feel the same way as you, or like, you do something and you feel like an absolute idiot. And then the next thing they text you and say, 'Oh my God, you'll never guess what I did.' And that makes you feel a bit better." The next slide. So to conclude from study 2, so what we found was delivering teaching and education within fast-paced clinical environments is really challenging. And these pressures can hinder progression of ACPs, particularly when they are unable to complete the workplace-based clinical assessments required for RChem e-portfolios. The Masters in Advanced programme was perceived as not providing sufficient clinical focus to fully support ACPs in developing the practical competencies required for their roles in the ED. Although tailoring the programme to meet the needs of every specialty is probably not feasible. However, it's essential that we identify alternative methods to help ACPs fill their recognised knowledge gaps. Issues around role identity continue to persist despite the implementation of more structured and supportive ACP training pathway. Enhanced peer support could play a valuable role in easing transitional challenges as ACPs move into their new role. So next slide. So now I want to talk about, well, what does all this mean for advanced clinical practitioner training? Next slide. So overall, what we found across the two studies is that having appropriate medical supervision is absolutely essential to ensure that ACPs feel supported during their workplace elements of their training. However, delivering formal teaching and supervision in fast-paced clinical environments remains a significant challenge. However, providing supervisors with protected time to facilitate teaching and supervision could help address this issue and enhance the overall quality of ACP development. We also found that in both studies, ACPs reported knowledge gaps, particularly in relation to clinical pathology. The Masters in Advanced Practice is a generic programme that's designed for ACPs across all specialties. While creating bespoke master's programmes for every specialty is unlikely to be feasible, there is a clear need to address these discipline-specific knowledge gaps. Supplementary specialties-focused learning opportunities or structured workplace teaching could help bridge this divide. The next one. Issues surrounding role identity were a prominent feature across both of these evaluations. Despite the progress that we are making to create a more through the multi-professional framework, uncertainty still persists among ACPs and their colleagues regarding what the ACP role entails and how it fits within the wider NHS workforce. Another one. ACPs frequently talked about the clinical aspects of the training, which is understandable given the current pressures within the NHS and a prioritisation of direct patient care. However, this focus risks overshadowing the other three pillars of the multi-professional framework, such as leadership, education and research. Thereby, this could limit the full potential and impact of the ACP role. So before I stop, I just want to say a huge thank you to everyone who gave up their time and to share their experiences as part of these evaluations. We recognise the NHS was experiencing immense pressure during the COVID-19 pandemic, and so particularly appreciative of people giving up their free time to come and talk to us and share their experiences. I also just want to say thank you to the Faculty of Advanced Practice, both in South Yorkshire and Bassetlaw and in the southwest of England. Their support was integral in helping us build relationships with the participating sites and also identifying ACPs to help us in deliver these two evaluations. And the final. So also thank you all to you for listening today. I've left my contact details up on there. So even after this webinar, if you want to get in touch to talk about this further, I'm willing to kind of chat to anyone. And also both of these studies I talked about today have been published and I've put the two references on there. So if anybody does want to follow up and read a little bit more about this, they are up online to look at. So thank you very much.